Welcome to G Fun Facts Online. Today, we're journeying into the heart of Africa, to the Democratic Republic of Congo, to unravel the story of how a nation, backed by the global community, turned the tide against one of the most feared diseases on Earth, Ebola. This isn't just a story of a virus. It's a story of resilience, innovation, and the profound power of human connection in the face of terror. The endgame for Ebola wasn't a single, dramatic victory. It was a painstaking, multifaceted strategy that rewrote the rulebook for fighting epidemics. The Democratic Republic of Congo's relationship with Ebola is longer and more bruising than any other nation's. The virus first emerged in 1976 near the Ebola River, an outbreak in Yambuku with a terrifying 88% case fatality rate. For the next 4 decades, the virus would periodically surface in remote areas, allowing for containment with traditional public health measures. But everything changed in August 2018. The country's 10th outbreak erupted in the eastern provinces of North Kivu and Ituri. This was a different beast entirely. It would become the second-largest Ebola epidemic in history, infecting over 470 people and claiming more than 280 lives. What made this outbreak so uniquely dangerous was its setting, a densely populated region plagued by decades of armed conflict. It was a perfect storm of disease and violence. Response teams weren't just fighting a deadly pathogen. They were facing deep-seated community mistrust and direct physical attacks. Yet, it was in the crucible of this devastating crisis that the modern, multi-pronged strategy for defeating Ebola was forged. The lessons learned here were so powerful that when subsequent outbreaks occurred, the response was faster and dramatically more effective, containing the virus with far fewer casualties. This rapid containment was no accident. It was the result of a revolutionized approach built on several crucial pillars. Defeating Ebola is like a military operation, where every component must work in perfect harmony. Let's break down the anatomy of that response. The first pillar is surveillance and diagnostics, the eyes of the epidemic. You can't stop an outbreak if you can't see it. This meant a relentless effort to find every single case. Health workers and community volunteers conducted active case finding, proactively searching for anyone with Ebola-like symptoms: fever, headache, vomiting. For every confirmed patient, a painstaking process of contact tracing began. This involved identifying and listing every single person the patient had been in contact with. These contacts were then monitored daily for 21 days, the maximum incubation period of the virus. Imagine the sheer scale of this task in a region where populations were constantly being displaced by conflict. But the real game changer was in diagnostics. In the past, samples had to be transported over long, difficult distances to a central lab, a process that could take days. Now, teams deployed advanced portable diagnostic tools, like the GeneXpert platform. This device could test a sample and confirm the presence of Ebola in under 100 minutes, right there in the field. Faster results meant patients were moved to care more quickly, and containment measures were enacted almost immediately, breaking chains of transmission before they could spiral out of control. The second, and perhaps most important, innovation was vaccination. The RVSV-ZEBOV vaccine, known commercially as Ervebo, was deployed for the first time on a large scale during that 10th outbreak. The strategy used was called ring vaccination. Instead of trying to immunize an entire population, this highly targeted approach focused on creating a protective buffer, or ring, around each confirmed case. This strategy involved vaccinating 3 specific groups. First, all identified direct contacts of a confirmed patient. Second, the contacts of those contacts. And third, all frontline workers, the doctors, nurses, burial team members, and lab technicians who were at the highest risk of exposure. This method proved remarkably effective. During the 2018 to 2020 outbreak, The vaccine was deployed just 1 week after the declaration. Ultimately, more than 300,000 people were vaccinated. It was a massive logistical undertaking, requiring a complex cold chain to keep the vaccine at ultra-low temperatures, often in areas with little to no electricity. But its success fundamentally altered the endgame for Ebola. The strategy was so successful it was used in all subsequent outbreaks, with over 35,000 people vaccinated in the 2025 Kasai outbreak alone. This leads us to the third pillar, which brought a powerful new message of hope: case management and therapeutics. For decades, an Ebola diagnosis was basically a death sentence, with fatality rates as high as 90%. The only option was supportive care, like rehydration and isolating Ebola treatment centers, or ETCs. These centers became places of fear, seen by communities as places people went to die, never to return. The response in the DRC saw a revolution in both the environment of care and the medicine itself. First, there was a conscious effort to humanize treatment. The terrifying name Isolation Center was replaced with Treatment Center, and innovative designs like the CUB, or Biosecure Emergency Care Unit for outbreaks, were introduced. These were individual, transparent patient rooms. They allowed medical staff to monitor patients closely without needing to wear full protective gear for every single interaction. But most importantly, they allowed patients to see their families in the outside world, fighting the profound psychological toll of isolation. But the most significant leap forward came from a clinical trial called PALM, a Swahili acronym for Together We Save Lives. This was a randomized controlled trial conducted right in the middle of the 10th outbreak, an unprecedented feat of research in a crisis zone. It tested 4 different investigational drugs and delivered a stunning result. 2 of them, monoclonal antibody cocktails named REGen-EB3, now called Inmazib, and MAB114, now called Ebanga, were found to be highly effective. For patients who received these treatments early in their illness, the survival rate soared to approximately 90%. Let that sink in. A disease that killed 9 out of 10 people was transformed into one where 9 out of 10 could survive. This breakthrough was monumental. It turned Ebola from an almost certain killer into a treatable disease, which in turn encouraged sick individuals to seek care earlier, further helping to stop the spread. The fourth pillar is the bedrock of any response: infection prevention and control, or IPC. Ebola spreads through direct contact with the bodily fluids of an infected person, whether they are living or deceased. Therefore, breaking every single link in that chain of transmission is paramount. This meant rigorously training healthcare workers on IPC protocols and ensuring a constant supply of personal protective equipment, or PPE. It also meant upgrading basic infrastructure, like water and sanitation, in local clinics and hospitals, many of which lacked reliable running water. A huge part of IPC focused on a culturally sensitive but incredibly high-risk practice: burials. Traditional funeral rites often involve washing and touching the body of the deceased. This is extremely dangerous, as the viral load is highest just after death. The response introduced safe and dignified burials, or SDB teams. These teams were composed of trained local community members who would manage the deceased safely, using protective gear, while still trying to respect cultural sensitivities as much as possible. Gaining community acceptance for this was a major challenge, but it was absolutely essential for stopping post-mortem transmission. Now we come to what was arguably the single most decisive factor in the entire fight, the one that made all the other pillars work: community engagement. All the medical technology and logistical firepower in the world is useless if the community you're trying to help is mistrustful or resistant. And this was the biggest lesson from the DRC's Ebola battles. The initial response in North Kivu was, by many accounts, a catastrophic failure of trust. The intervention was perceived by many locals as a top-down, foreign-led effort that ignored their culture, their fears, and their needs. A heavily securitized approach, with armed guards at clinics and coercive measures, bred suspicion and outright hostility. Rumors spread like wildfire. People claimed Ebola was a hoax, or a money-making scheme they called Ebola business, or even a political plot to destabilize the region. This mistrust manifested in the worst ways imaginable. Patients would hide from health authorities. Sick individuals consulted traditional healers instead of going to treatment centers. And in a shocking wave of violence, response centers were torched, and health workers were attacked and even killed. The population began to see the response itself as a threat, not just the virus. Faced with a failing strategy, the government and its international partners were forced to make a radical pivot. They moved away from a purely biomedical approach to one centered on genuine two-way dialogue with the community. This wasn't just about broadcasting messages, it was about listening. The new strategy involved empowering trusted local figures, village chiefs, religious leaders, youth organizers, and even traditional healers to become advocates for the response. Their word carried more weight than any outside expert. Instead of outsiders dictating terms, communities were given ownership. Local residents were hired and trained to work as contact tracers, hygienists, and members of those crucial safe and dignified burial teams. In one powerful example, when a treatment center was needed, the community itself mobilized to transport materials by hand to speed up its construction, a clear sign of their commitment once they felt included. Response teams also started listening to feedback and adapting. When it became clear that the intense focus on Ebola was ignoring other pressing health needs, the response was better integrated into the broader primary healthcare system. The World Bank even supported a Cash for Work program to provide temporary jobs, which helped build goodwill. To fight rumors of corruption, some programs even used public lotteries to select participants, ensuring total transparency. This shift was transformative. Trust, slowly and painstakingly, began to be rebuilt. Communities started to see the response as a partnership, not an imposition. This grassroots collaboration was the final ingredient that allowed the vaccines, treatments, and surveillance systems to finally become effective. The success is even more remarkable when you consider the extreme adversity. In the Kivas, teams were operating in an active war zone. Intense violence could paralyze all activities, allowing the virus to spread unchecked. In a 2025 outbreak, the epicenter in Bulape was so remote that it took 3 days to reach by road, requiring a heavy reliance on helicopters. In the early days there was a shortage of everything, including clean water, which had to be supplied by laying 1.5 kilometers of piping to the local hospital. Of course, no single entity could have defeated Ebola alone. This was a massive collaboration. The DRC Ministry of Health led the charge, coordinating a vast network. The World Health Organization provided technical leadership. On-the-ground implementation was carried out by NGOs like Médecins Sans Frontières, Alima, and the Red Cross. Critical funding and support came from partners like USAID, the U.S. Centers for Disease Control, and the World Bank. The United States alone provided nearly $600 million for the 2018 to 2020 outbreak. And it was also a story of African solidarity, with experts from Guinea who had battled the West African outbreak, traveling to the DRC to train their Congolese counterparts. The official end of an Ebola outbreak is declared after 42 days. That's twice the maximum incubation period have passed since the last confirmed case tested negative. That countdown is a tense wait, but its successful conclusion marks a profound victory. The legacy of this fight is complex. For the thousands of survivors, the journey continues, often with long-term health problems and significant social stigma. But the enduring legacy is one of strength. The immense capacity built to fight Ebola, the rapid response teams, advanced labs, and community engagement models has been repurposed to strengthen the DRC's entire health system, proving vital in responding to other threats, including the COVID-19 pandemic. The ultimate lesson from the DRC's long war with Ebola is that to defeat a virus that thrives on contact, the most powerful strategy is connection. It's the connection forged between 21st century science and the age-old wisdom of community trust. It's the bond between doctors, governments, and the communities themselves. The end of the Ebola nightmare in the DRC is a testament to human ingenuity and the unbreakable spirit of a nation that refused to be defined by its longest and most terrifying public health battle.